Thank you for joining us today. As Mike said, we're going to talk about an article recently published about the introduction of videolaryngoscopy into a pre-hospital service. So this article, I think, was published earlier this month in the Emergency Medicine Journal, and I think, as you probably see from the author affiliations, was took place at Magpass, so in the northeast of, in the east of England, not far from our patch. In order, as a kind of rough framework for how we're going to go through this, this article is a quality improvement project rather than kind of de facto research, and so rather than using the kind of traditional CASP stuff, we're going to use these frameworks set out by Hempel et al. In 2015, which just gives a kind of outline of the different criteria which you should assess when you're looking at a quality improvement project and how useful it is and what it needs to cover. So we'll start with kind of organizational motivation and intervention rationale. I've kind of lumped them together. I don't need to really lecture anybody listening in to this journal club about how important airway management is in the pre-hospital arena, and how the environment in itself, as well as the patient burden and the reasons why we're doing our RSIs, can often lead to airways presenting more difficulty than they would do in an in-hospital environment. The complications associated with difficult intubation are also kind of manyfold and quite significant. And again, I don't really need to lecture you on that. Overall, I think success rates at intubation really vary depending on the service, but the literature, there's lots and lots of literature from kind of the around 2010 to 2015 about this, publicizing different services success rates, but it varies between about 85 and 99%. Videolaryngoscopy is kind of intuitively a nice solution to difficult airway. It's well established in hospital practice and has been recommended by lots of guidelines as a means of improving success, especially with predicted difficult airways. It definitely is known to be associated with less force and repositioning, which should lead to less C-spine movement, though that is debated. The authors, in terms of justifying this project, have also said that it has been and they've quoted some literature that it's associated with reduced viral transmission, which perhaps is more of a recent concern than a long-established one, but in theory, the intubator, the operator's face is further from the glottis with a video technique. And then just briefly that they've chosen a videolaryngoscope that can be used as a direct laryngoscope to try and reduce some of the complications that have been recognized in other projects looking at the introduction of videolaryngoscopy and some of the difficulties using them. So that's really why they've gone on to do that. And then just briefly to describe then the intervention, the actual laryngoscope videolaryngoscope they chose to use, and the a few of the features of the organisation. So Magpass is based in the east of England, as I said. It's a physician and paramedic team, and slightly differently from LAA, they are both fully trained and competent in intubation. And I'm not entirely. It doesn't say explicitly in the paper how they decide who's going to intubate, but definitely they job about and take it in turns depending on team composition. They implemented, well, their study period is from 2016 to 2020, although they didn't actually bring in the intervention until 2017. And they quote that they have a baseline first attempt success at intubation rate of 85%. And their reasoning around introducing the videolaryngoscope was to improve their safety and success. And by success, I think they mean their first attempt success, although they don't actually quote their overall intubation success or difficult airway or need to fall back on their kind of rates of airway complications. The videolaryngoscope they chose was the McGrath Mac EMS. A big advantage of this laryngoscope is that it can be used for DL as well as VL, because the blade is a Macintosh blade. So you can either do DL or VL with Macintosh blades, and then they have the hyperangulated blade for use in predicted anterior larynxes or predicted difficult airways. The reason they chose the McGrath over the CMAC is because the battery is easily replaced. It's a disposable battery that clips on the side of the device, so that it doesn't require charging, which was an attractive feature to them. They introduced it, their training package consisted of a pre-reading, an instructional video, medium fidelity simulation, and then an in-person assessment of competence. And then teams were good to use the device. And that's just a picture of it. It's obviously quite small and lightweight. There was no change in their physician training during their study period. Typically, they say they don't give exact numbers. Most of their physicians are emergency medicine physicians with between 100 and 500 direct laryngoscopies kind of on their portfolios during their careers. And then obviously the paramedic cohort is critical care paramedics. They say they had no change in their induction or intubation SOPs during the study period, nor in the bougies or other airway equipment that we used, though that's not entirely true, as we'll come to a bit later. Team configuration, tasking, everything about their jobs was unchanged during the study period. The SOP for device introduction was the first attempt at intubation should be with using the video laryngoscopy with a Mac blade. They could use it again on the same, if something else, much like our second intubation attempt, like most FEAR kind of airway guidelines. The second attempt, you could use the same blade if you'd swap something else, such as position or of patient or something. And then you could also change your hyperangulated blade if the larynx was anterior. They didn't prohibit the use of direct laryngoscopy, and they continued to carry it as a backup for technical failure, but they encouraged people to use video laryngoscopy as a first line. So next, if we talk about the study, kind of the structure of the study design and how they controlled it. Fan et al., 11 years ago now, described different structures or different study designs for quality improvement research, they've called it, which is problematic language in itself, but quality improvement projects. So they can be kind of properly designed in a research style with individual patients or clusters randomized, or in non-randomized designs where interventions are introduced in a stepwise fashion, either through different kind of segmented cohorts within the overall cohort, or in a time series design, so different groups get it at different stages, and the groups then act as their own controls. Controlled before or after studies also possible, but this is essentially an uncontrolled before or after study. So the only essentially the entire service was subjected to the intervention at the same time. So there's no clear control, but they've used some clever statistics, which I will describe, to get around that, to try and get around the implications of that. In terms of where the data came from and what they chose to measure, they relied on routine data collection, which was all entered into HemSpace. So already prior to the study, HemSpace records laryngoscope type, the blade chosen, the view obtained, and the number of attempts to intubate. These are kind of relatively objective outcomes. And then the other outcomes that they recorded were first intubation success, so that they pulled intubation-related hypoxia, so a drop in saturations of more than 10% over 2 measurements, and the view of laryngeal inlet. These are all quite objective endpoints or outcomes, and they describe them as clinically significant. Obviously, the hypoxia and first attempt intubation is, the view of the laryngeal outlet isn't necessarily so directly clinically significant. But they all do rely on self-reporting by the users. They supplemented their project with an online survey. I think they got about 60% response rate from all of the paramedics and doctor cohort about how they felt about using the device. And they collected data from the start of January in 2016 until the end of February last year, and introduced the videolaryngoscope about halfway through that time, so towards the end of 2017. So they were essentially trying to use the first part of their study period as a control for the second part. And in order to make that possible, they've used something called statistical process control, which is something I'd never heard of before. It's a kind of, so it's described in this paper that outlines its purpose as is combining rigorous time series analysis methods with a graphical presentation of the data. And the idea is fairly obvious, probably to all of you listening, that obviously any variables, any outcomes measured are subject to an inherent variability over time. Our rates don't remain kind of specific to the decimal, our success rates, for example. And they are subject to just variation as a result of what they call natural or common causes. The point of statistical process charts are that if you have a period of data collection prior to your intervention, you can kind of analyze that variation, and then when you introduce a new
is in the blizzard blanket to kind of maintain thermoregulation. And I guess this is for a baby that you've identified by doing your drying and by your clinical experience. This is a baby born in a poor condition.
Mike, I'm confused.
This is a baby born in a well condition. Then you dry baby, wet baby, and give baby to mum.
Me too. Mike, I can't see.
Sorry, I think somebody had a their mic on.
Okay. Hopefully the baby's warm enough.
Yeah.
So we have. So this isn't that exciting, this particular concept, but essentially you have natural common cause variation, and you want to identify whether your intervention causes the kind of rumbling fluctuations to be significantly changed and significantly deviated from your normal kind of fluctuations, and that they call significant special cause variation. So this is just an example from the paper describing the process. You can see that it rumbles along between two control lines, the kind of upper and lower control limits. And when they've introduced their intervention in this example, the variation is now rumbling along, and it's crossing that control line, and that suggests that the intervention has had a significant impact. The authors kind of advocate this as a good, nice visual way of analysing data, and they argue that one of the benefits is that it's quite pragmatic. So you don't have to define a kind of prolonged or a specific number of data points to be collected or a specific time to observe to conduct your study for, because you can base it on ongoing analysis of the SPC charts as they're generated through your study, and you can analyze your data as they're produced. So this is obviously quite different from conventional research, and it's much more based around quality improvement projects which need kind of answers for services in a more pragmatic fashion. We've talked a little bit about the confounders. They argue they kept everything else constant, but they didn't discuss they didn't record which operators were using the devices or conducting the interventions, and they didn't specifically define anaesthetists from emergency medicine physicians. And I'm quite unclear about whether they defined their own study period or whether they used the SPC charts to try and to decide when to stop recording data. They don't kind of express any kind of in their planning and their study design. There's no kind of planned recruitment numbers or anything like that, or power calculations. The results during the 4 years that they collected data, 919 patients underwent advanced airway management, averaging, they've said, 18 per month. About half of these patients were in cardiac arrest or ROSC patients, which is quite obviously distinct from our services kind of airway experience. They and linked to that, they also record kind of how many patients have rocuronium prior to laryngoscopy, and there's slightly more patients seem to be receiving it post videolaryngoscopy introduction. There's no kind of comment on significance, and I'm not sure why that's reported. Their indications for airway management are kind of listed in this little paragraph here: failure to maintain an airway, failure to protect an airway, failures to oxygenate or ventilate, cardiac arrest, or anticipated clinical course. So in 70 patients, following the introduction of videolaryngoscopy, direct laryngoscopy was used as a primary tool in 70 patients. 35 of those, it was due to airway soiling, and another 40 of those, it was due to what's described as a crash airway management, so a cold tube requiring kind of immediate intervention. And I think in their discussion, they've explored that being just because people are defaulting to what's most familiar when there's the most urgency. The first pass rate between the two devices, direct laryngoscope and videolaryngoscope, is comparable. And first attempt success rate with the videolaryngoscope is comparable for paramedics and physicians, as you can see. The two tables show a little bit of the demographics of the patients that they were attending during the period before. The direct laryngoscopy period is prior to October 2017, and the video laryngoscopy post. And then it shows a little bit the variation in laryngeal views and table 2. This is laryngeal views and the number of intubation attempts. Importantly, they record they report the data they report the cases where the data is not reported, the outcome is not reported. So missing data. It's fairly precise in terms of reporting, but it doesn't, so that's what just shown there. But it doesn't at any point talk about how many patients, how many incidents there were of abandoning video laryngoscopy once it started for direct laryngoscopy. So it's very unclear from the results what the adherence was to the intervention. In those predicted to have a difficult airway, so again, 36% were intubated on first attempt using direct laryngoscopy versus 31% using video laryngoscopy, so kind of pre and post the intervention. This is not a significant difference between those two groups. And the hyperangulated blade was only actually used 5 times. There were no technical failures during the study period of the VL, and no complications that they've reported being directly attributable. Their main outcomes are in these 3 SPC charts. So this first one in the top left of the screen is showing their monthly first attempt success rates before and after the introduction of video laryngoscopy, and then after their bougie was changed. And this isn't massively discussed in the paper, but they've changed at this point from a gum elastic bougie to a more rigid bougie, which holds its shape a bit better. I think that's in reaction to difficulties passing an ET tube despite a good view of the glottis, which again I'll discuss later. The monthly expectation is the control for a lower control limit that we discussed before. So for which was this one? For first attempt at intubation success, intubation rates, the monthly expectation before the intervention from the SPC charts was between 50 to 100%. So it's slightly unclear to me how you would improve notably on that, given that it's kind of difficult to go above 100%. And some months they are achieving 100% first pass success rate. Similarly, with the SPC chart below, so intubations without hypoxia, as previously described, shows they have a monthly expectation of 82 to 100% of all intubations taking place without an episode of hypoxia. And as you can see, that's unchanged after the introduction of videolaryngoscopy. And then the last one to the right, figure 3, is what is the frequency or the rate of seeing good laryngeal inlet views. That's described as a 1 or 2 Cormack grade. So again, it's between 70 and 100% usually, and that's unchanged post VL introduction. In terms of results of their survey, they got 61% response to their survey. Many people reported that, and it's a very much a qualitative effort, this, in terms of just exploring how the organisation felt about it. Many people reported improved situational awareness, and that's especially appreciated by assistants, not assistants, but by the airway assistant, who felt like they had much better understanding of what the operator was seeing. Many people reported improved glottic view, but despite that, there's a common complaint of difficulty instrumenting the trachea despite the improved glottic view. The device performed poorly in bright light and felt different to a normal laryngoscope, which was reportedly not a good feature. However, despite these factors, 95% of respondents wish to keep the laryngoscope for certain purposes. One of the unintended, so it's slightly surprising in some respects that kind of the poor performance in bright light and the difficulty instrumenting the trachea despite the improved glottic view have come up, in that these are kind of very predictable problems associated with videolaryngoscopy, but kind of have been extensively described elsewhere. They also discuss an unexpected, unintended consequence was distraction. And as a result of the operator being focused on the videolaryngoscopy, they may have had actually negatively impacted situational awareness with regards to hypoxia, patient monitoring, and other factors going on in the scene, because of the shared situational awareness of what was actually going on around the glottis. And then again, the bougie was changed during the study period, which kind of was fed in, was a result of some of the feedback that they were receiving, and not entirely kind of in keeping with keeping everything else consistent. Lastly, I've just discussed, I've missed a few sections of these tables, but lastly, I'll just discuss the limitations of the study as identified by the authors. One of the limitations that they mention is that there's no control for the experience amongst the physicians that rotate in a 6-monthly fashion. Obviously, they continued rotating throughout the study period. And they may have had different kind of cohorts of anaesthetists versus emergency medicine physicians, experienced emergency medicine physicians versus much less experienced ones. But that's a very difficult thing for them to control for this purposes of the study, and that they didn't use any other VL devices. They do say they had a look at a few and they chose this one. But they didn't really discuss the criteria beyond the fact that this one doesn't need to be charged. The other kind of area that needs to be kind of discussed, they've said that despite these limitations, the results of this study should be generalizable to other services, particularly because of the kind of the homogenizing of a training program that is being rolled out amongst many air ambulances in order to comply with the GMC criteria for pre-hospital emergency medicine training. And so they've said on the basis of this that the findings of this study should be generalizable. And I think it's quite important just to point out that
Chloe, I think we lost you.
You've lost me.
You're back now. Your microphone's been fading in and out a bit.
Oh, sorry. It's my headphones, probably.
Yeah, they may be dying if they're earbuds.
Sorry, can you hear me now?
Yep.
Yep. Just briefly, the difference between quality improvement and research is just important to flag. So the Health Research Authority defines things that any attempt to derive generalizable or transferable new knowledge as research rather than quality improvement, and that's just it's a little transgression in terms of I think, to be fair, just in terms of I haven't got the words, but which semantics almost, that they're talking about generalizing these their findings, which is inappropriate really for something that defines itself as quality improvement. In terms of other limitations, in my opinion, I think the study design and duration, how many laryngoscopies they felt they needed to conduct before they could be certain that the device didn't impact on them. I'm unclear on how that was defined, and I think it's probably part and parcel of the SPC charts, but not being an expert on those and not really seeing much, not really having much discussion of their utility in the paper, I'm a little uncertain of how they decided to cut off their data collection. The training and the understanding of videolaryngoscopy concerns me a little bit, in that a lot of the feedback from it is fairly predictable and could have been, in terms of instrumenting, viewing versus instrumenting the glottis, could have been addressed during training and implementation, I would have hoped. Adherence, I've already mentioned. I don't know how many times it was abandoned or thrown away, and a normal handle and blade picked up. If at all, I think it would be helpful to know that. Intubation failure rate overall, prior or post intervention, isn't discussed at all in this paper. I assume it's very low, but I don't know whether that's the case. And just in terms of the endpoints, as I said, already they were achieving almost 100% on a lot of those endpoints. So actually impacting them without doing kind of massive multi-center, huge numbers of patients involved to impact on kind of the endpoints that they chose would have been very, very difficult in reality. And actually what you want to be doing is avoiding third and fourth attempts at instrumenting the airway and focusing on the hypoxia, arguably, but it is useful. But the endpoints, I wonder how clinically useful they are, but also achievable. They were right from the outset of the study. Their findings are very much in keeping with other pre-hospital studies of introducing videolaryngoscopy. So in Germany, they did a big multi-center RCT with different devices and had a first attempt success rate of 85% with the CMAC. Austria, again, another big RCT, multi-center RCT. They found that the two devices were equivalent, direct versus videolaryngoscopy was equivalent, and didn't change. So, and overall had a success rate of 98% with no change in the number of attempts. Again, I mean, you can read these yourself. There's a big meta-analysis from 2017 saying that in those with significant experience, VL doesn't improve performance. It may in fact worsen it, but it may improve performance in those with less experience. And then in Denmark, they found no change through the introduction of graph-mac, though they did change some other things. in their study. In terms of whether the results are useful to us at LAA, we do have a 2-person physician paramedic team for all of our RSIs, as they do. But beyond that, I think there's some really significant differences between the services. Their medical crash intubations are significantly more frequent, which arguably also leads to more intubations on the floor and in difficult positions without optimizing the things that we would expect to optimize in a planned RSI, even an emergent RSI. Physicians and paramedics can job about there. That's not our model. And though how relevant that is to this question, I don't know. They discuss a modified rapid sequence induction technique. I don't know what that is. I don't know if they just meant that just means that they use fentanyl, or if they're doing something else differently from us. And whether we have a problem to solve is again a difficult one to know. I don't have our first pass success rate to hand, unfortunately, but obviously we know that we have over the last 8 years over a 99% success rate at intubation, and we're doing considerably more intubations per month than that service. And because we don't job about, those intubations are condensed again just into the physician cohort. So as individuals, we are doing significantly more intubations a month than our peers at MedPass. Here are my references, and I'm going to stop sharing my screen now. If that's okay, Mike.
Yeah, that's great. Thanks for that great presentation. Well, let me just get the view set up so I can actually see everybody. Oh, there you are. So feel free to come on video now if you want to be famous, and we'll do some questions. So there's a few different things that you covered off most of the points that that we discussed previously, and that I think are really important for this. I think there's a few that are worth just readdressing, but one you hadn't brought up that I was also curious about. So one of the things that's interesting about this, and I've seen McGrath, but not used it clinically. I'm more experienced with the CMAC and GlideScope. But one of the things I do notice about the plastic blade in that is that, you know, we have to always think that the device, even though it's it has the ability to do direct laryngoscopy, it has a regular MAC shape blade, it may not be the exact same as a MAC blade, because a study that was done by our service a number of years back shows that not all blades are the same. And particularly it looked at the plastic disposable blades versus metal blades, and even though both the same MAC design, the plastic blades were all associated with a 1 grade lower in view that was obtained when they were introduced to the service. And that, I think, was predominantly associated with the flexibility of the blade, because a lot of the plastic disposable ones are a lot more flexible, but also may have something to do with, I think, and when I look at the McGrath one, particularly the slipperiness to a degree sometimes of the blade, and as you go in just trying to get a hold on the tongue and move things out of your way and stuff, I think the materials and things that are made of sometimes may be slightly different. So I'm not sure if that, you know, maybe playing a view or playing a sort of a part in terms of why they didn't necessarily see a lot of benefit. The other thing, and they don't really discuss this in their study, and I think it's really hard to sort of to tease out, but with this device where you can do either direct laryngoscopy or videolaryngoscopy, is truly understanding what people were doing when they were using this, because although it's got a camera stuck on the end of it and then a little monitor, it doesn't necessarily mean that people were using it all the time. And especially those clinicians that are much more used to doing direct laryngoscopy, you don't really know how often they actually were doing direct versus video. And I think this comes back to your training point, is that it's really in some ways different techniques when you're trying to do one versus the other. And I, back home, when I introduced video laryngoscopy into our intensive care unit, I spent a lot of time teaching people and explaining to them using sort of a Canadian analogy that it's kind of like akin to roller skating is to rollerblading. They both really similar. You both have something that's sort of a skate boot, but one's on ice and one's on with inline blades, and you have to approach it differently. And that's one of the things, particularly with VL, that I think, and it's very highly suggested based on their comments about the view being so great, is that one of the things that common errors that people make with videolaryngoscopy is to ram the camera in so close that you have this amazing view of the glottis, but you have no room to actually get your tube in, and you can never actually work the angles and stuff. And that's one of the things about teaching people how to do videolaryngoscopy, is you actually need a slightly different view than you get when you're doing direct laryngoscopy to achieve the best results. So if people are trying to use this device as a direct laryngoscopy and sort of going back and forth between the camera and their direct view, they might not actually end up performing quite as well as they would if they were trying to use it properly and solely as either videolaryngoscopy or properly and solely as a direct laryngoscopy. So yeah, so really interesting things to think about how we would tease this out. Are you, oh, sorry, I just got a message from Ewald saying that he was losing the connection, but I take it he's there now and you can see everything. Okay, so others, there's some other stuff we can dig into in the paper as well, but any other comments or questions for Chloe at the moment?
I was wondering, Chloe, what you found of the
How does that
I think
sound?
we lost him. I know. Why don't you make up an answer and then we'll see if it fits his question when he comes back online.
No, I can't imagine what he's going to ask.
Maybe he'll dial back in a second. The helipad video Wi-Fi is dodgy sometimes. Harriet, did you have any questions? You're on mute still. Oh no, you're not. You're off. Oh, I think her microphone's not working.
She's fixing something.
Yeah.
I think it's an interesting. Your mic's broken. Okay, type your question.
Okay.
We'll look out for it.
Right.
I think it's interesting because I think it's actually a really useful contribution and what is useful, really, really useful for us to try and kind of guide our questions that we want to ask when we do this. But I just think it's presented as slightly different beast from what it actually is.
Yeah, I think it's really, and it is a little bit telling in their final statement. So this thing around research versus quality improvement and stuff like that is interesting because there's a semantic side to it, which is somewhat, as you mentioned. There's also definitely an ethics side to it in that we're using patients' data with how we have the right to access patient data and then share it is very clearly specified under sort of legal and ethical frameworks. And for the research framework, there's a requirement for having appropriate approvals, and that's why they sort of have that divide. So it's slightly more than semantics. The other, the other thing is that depending on what you're trying to answer, they're very different. So I do think that they're trying to almost do a research study, and they wanted to show that, and their question was not, can we make our service better, which is a quality improvement question. Can we improve the number of first pass intubations with this or other types of interventions? I think they were trying to answer the question is, does videolaryngoscopy improve your first pass success or your intubation success? And because how you would design the study and how you would design a quality improvement project is slightly different, in that in a quality improvement project, I would have had much shorter cycles of analysis and then interventions and changes, and would have ideally caught some of the stuff like people using it incorrectly very early on, and then continued to evolve and see if I could, if you could increase your rates. Yeah.
Which is how that SBC malarkey is supposed to work, I think, isn't it?
Yeah, exactly. So that you can tell when you've reached your threshold with the multiple intervention sort of model. And the other thing that comes down to is their endpoint that, as you pointed out, if you're really trying to measure the impact of videolaryngoscopy and it's sort of as a research question anyways on and improving care for patients, if you have an incredibly high first pass success, you're unlikely to ever measure and show a difference there. And what you're really looking for, and you wouldn't really expect it to make a difference, because if it's easy to intubate the patient, it's easy to intubate the patient. You don't need anything, better to do it. You may just show it's worse, and you're unlikely to show it's better. But what you really want to do, as you say, is have a device that may bail you out in those rare critical situations. But if you're doing that, that's what you need to measure. And that's what they didn't measure really in their study is how often do they have those failures. But it is hard, as you said, because they're so infrequent, luckily, that you do need a really large trial to show that. Sorry, Harriet, do you have a microphone again now?
No, so Harriet's. Oh, go on. Go on, Harriet.
You briefly said that they didn't differentiate between background of physician, and I just wondered what your thoughts are on that, because clearly there'll be different levels of experience and use coming to that, but it's interesting they didn't choose to explore that.
Yeah, I think so they do. The only comments in terms of operator that they make are that the majority of their doctors are emergency medicine, and that actually I think the majority of intubations, or 2/3 of intubations, are done by paramedics and 1/3 by doctors. So over the study period, the paramedics got a lot more experience with the VLs, and they comment on that, but they don't comment on what the doctors are, and they don't comment on what the background of the kind of intervention team was. They don't comment on who designed the training package or who signed people off as being competent to use the VL.
Yeah.
I don't know what the first author is. I do know what the second author is, and she is not an anaesthetist. And I don't know what the third author is. But I think he may be ambulance service.
Yeah.
I don't know them. But in principle, it's different. It's hard to know exactly what experience was brought to the table, how much support they got from the company in terms of training, and things like that. I don't know the answer to, and I think it's quite important.
And I think in terms of kind of, if you've got people who are really comfortable and happy and actively promoting a new piece of kit, then there potentially is more reason for those views and there's more buy-in, they'll do more training on base. But if you've got people whose default and comfort area is something else, then that will go the other way. So I just wondered if there was any thought, but it didn't look like there was going through it.
No, I don't know. One of the reasons they may not have been able to report is because I don't know how many anaesthetists they do actually have at any one time. Their physician cohort is relatively small, so you probably run the risk of starting to individualise.
Yeah,
the reporters, which may be one of the reasons they haven't done it. But it's, I don't know.
Yeah, and it is interesting.
Really,
I'm sorry, go ahead.
No, I was going to say I'm really sorry. I'm going to have to go.
Okay.
Thanks
for joining us.
But I'll watch the last 15 minutes of the recording, and thank you very much, Flo. That's really
Thank you.
Right.
Thanks for coming.
Okay. Bye.
I think we're going to be wrapping up in a minute anyways. I think the one thing to comment on is just that, so I'm not 100% sure that that obviously the flavor of doctor you are, so the core specialty in of itself necessarily is a major factor. I think what's more important, which is obviously associated probably with your core specialty, is the number of actual intubations you've done, but also in particular the amount of time and experience you've had with videolaryngoscopy beforehand, and then your understanding of airway management and videolaryngoscopy and all that stuff, so you can teach it to somebody else. I think those are the things that are doing it. And I'm sure there's emergency physicians that are excellent at that. There's intensivists, there's anesthetists, but then there's also people that that may not, just because of their specialty, have nearly as much training in those areas. So I think by default you end up with a little bit higher experience rate and knowledge understanding in an anesthetic group, but it doesn't mean that it's the only way to have it. So, all right.
No, agreed.
Any other questions at all? Okay, well, thanks, Chloe. That was really great. And I think we'll stop our recording here.